So today's topic is embryology of fetus and factors influencing fetal growth. It's a vast topic and we'll be kind of rushing through it. So that is the topic, but what we are going to do is make a baby. Okay, so what are the ingredients required to make a baby? We need a sperm, we need ovum, and we need a vessel. If anybody you have cooked, you know you need a vessel, and that vessel is uterine or endometrial cavity. To cook anything you require heat source, and our source is mother's body, and the time we take to prepare that dish or the baby is 280 days. And what we get after 280 days? Placenta, which we are not going to use, and baby, which we are going to raise. So this is what we'll get. What is embryology? You all know what embryology is. Embryology is a science where we study from fertilization till growth. Embryology, we study from fertilization till development. Alright, that is embryology. The definitions and all are there. You can read it, you can go see it in the books. But we are here to understand the topic, and this is what embryology means. There are two aspects to embryology, ontogeny and phylogeny. Ontogeny means fertilization till death of an individual. Okay, we study the life cycle of an individual from fertilization till death, and in phylogeny, we study evolution of species, like the evolution of human species, not the individual, the entire species. And human development has two parts, the prenatal, that is before birth within the uterus, and postnatal, that is after birth. Now, there are a lot of terminologies here. So, the top one is oocyte, right? Oocyte is the female germ cell, and the oocyte that humans have is secondary oocyte. It's stuck in meiosis 1. Sperm, of course, from the male germ cell, zygote. When a sperm and ovum meet, the first cell formed is called zygote. Then what happens? The zygote divides into two cells, and that process is called cleavage. And the cells that are produced are called blastomeres. In the initial phase, what happens is that the zygote remains of the same size. The blastomeres keep on forming. The total size remains same. So the individual cell size keep on decreasing as the division goes on, right? Then we'll morula. We have all studied morula. Morula is 12 to 32 cell structure, right? Why we call it morula? It looks like the mulberry, like the mulberry. That's why we call it morula. Like morula is the Latin for mulberry. In the top is morula, the portion that has been cut off. It is actually mentioning morula. Morula has 12 to 32 cells, and it is formed after cleavage of zygote. Then we have blastocyst. When there is fluid collection in morula, what forms is called blastocyst. And blastocyst is the entity that implants in the endometrial cavity, right? Implantation. What is implantation? Like the baby or the embryo has to attach somewhere, and it attaches into the endometrial cavity, and that process is called implantation. Gastrula. We are three-layered structure. We have ectoderm, we have endoderm, we have mesoderm. So when a bilaminar disc is converted into trilaminar disc or trilaminar structure, we call that process as gastrulation. Neurula, the stage in which we find that the neural tube is developing, that stage is called neurula. 56, the top portion that has been cut is actually mentioning the definition of embryo. Embryo is till 8th week of gestation. Beyond 8th week, we call it fetus. Till first 2 weeks, we call it zygote. Okay. Fetus is after 8th week of pregnancy. Abortion, I think many of you have attended my lectures in the clinics. Abortion is any delivery that happens, termination of pregnancy before 20 completed weeks is called abortion. Trimester is the 3 calendar months of pregnancy. We call a pregnancy to be a 9-month period. So we have 3 trimesters. Every 3 calendar month is considered a trimester. The first trimester is most important because the majority of development, means the entire development actually happens in the first trimester. In the rest of trimester, that thing evolves, it grows. That is how it is. Congenital anomalies, the anomalies present at birth. So of course you can understand the anomalies happen during the development of the embryo. The postnatal period, the changes that happen after birth. Again, the 3 stages, zygote is the first 2 weeks, embryonic stage is 3rd till 8th week, and beyond 8th week we call it fetus. This is the entire cycle. Ovum, sperm, then we form the zygote there. They are dividing, we form the morula on day 3. There is a blastocyst forming there, and that blastocyst is getting implanted. Gametogenesis, will just glance over it. You know what gametogenesis is. The diploid organism gives rise to haploid cells. So these are not just haploid cells, okay. There is crossing over. That is the speciality of our gametes, that there is crossing over. That is how you are not exactly like your parents, you are a variation of your parents, right? Your genetic profile is not exactly like half is of your mother and half is of your father. It's a mix of both of it, right? So spermatogenesis and oogenesis are the different processes. There are some specific things. The spermatogenesis, the entire procedure duration it takes is 2 months. It takes 2 months for the entire process of spermatogenesis. Is divided into 2 parts. Spermatocytogenesis, that means cell division is happening, and in spermiogenesis, maturation is happening. That we get a motile sperm, right? The formation of sperm starts at puberty. Remember that it is not forming while the baby is still in uterus. It happens at puberty and it continues till death. As far as females are concerned, new oocytes are not formed after birth. And at birth, all oocytes are arrested in first meiotic phase. All the oocytes. So a woman is born, a lady is born with primary oocytes only. Right? There is no further formation of new oocytes. Once a female achieves puberty, before ovulation, a secondary oocyte is formed, and the entire process of meiosis is completed only after fertilization. Like when the sperm meets the ovum, the process of meiotic division in ovum is completed. So for fertilization to happen, sperm should be present in the fallopian tube at the time of ovulation, because the life of ovum is very limited and it's nearly 24 hours. Right? So if the sperm is not present in that duration, fertilization cannot happen. Also do remember that fertilization happens in the ampulla of fallopian tube. So the sperm has to be present in the ampulla of fallopian tube. So the intercourse should happen around 2 days prior or on the day of ovulation. This is, of course, you all know, uterus, cervix, vagina, ovary and fallopian tubes, the female genitalia. A uterus has 2 parts, the body and cervix, and it has 3 layers, perimetrium, myometrium and endometrium. The fallopian tube is 10 to 12 centimeters. It's a tubal structure. The main aim of fallopian tube is to carry the ovum from ovary to uterus and to bring sperm from uterus to ampulla, where the fertilization happens. Once the ovum is fertilized by a sperm and a zygote is formed, the zygote is then again transported to uterine cavity by the fallopian tubes. And for descriptive purpose, we divide the fallopian tube into 4 parts. The infundibulum, or the fingery portion, which catches the ovum. Then we have ampulla, or the dilated portion, where the fertilization actually happens. Then we have a small straight portion, isthmus, and then we have the interstitial portion, which is buried inside the myometrium. The cleavage of zygote starts after 30 hours of fertilization. What is cleavage of zygote? Again, it is the mitotic division, series of mitotic division that happens in zygote after fertilization. During the initial phase, the size of zygote does not increase, means the total size does not increase. The cell keeps on getting smaller. In 12 to 32, when the cells are, there are 12 to 32 cells, we call it morula. And the internal cells of morula, there is an arrangement inside morula. There is a compaction, that the morula gets compacted. It becomes very tightly opposed to each other. There is an inner cell and there is an outer cell layer. Okay? And morula is formed on day 3. So this is the entire process. Morula is a 32 cell stage. And besides that is blastocyst. This is the cavity, the fluid-filled cavity. Then formation of blastocyst. The formation of blastocyst happens when the fluid from uterine endometrial cavity enters into the morula. Why does the fluid enter? There are many chemical changes that is constantly going on inside the morula, and slowly and steadily the fluid sips in. Once the fluid comes in, there is a cavity formation. This is the cavity. And the entire blastocyst is this. This is the outer layer, trophoblast, and this is the inner cell mass. The inner cell mass gives rise to the embryo, and the outer trophoblast gives rise to the placenta. Right? And this is the cavity, it's fluid filled. So blastocyst attaches to the endometrium on around day 6-7 after tearing through zona pellucida. Remember, the zona pellucida is constantly covering till morula. Right? Once the blastocyst is formed, it breaks out. Now, in the second week, the bilaminar structure is formed. The inner cell mass organizes into two layers, the hypoblast and the epiblast. This is the bilaminar disc. This is the epiblast, this is the hypoblast. Okay. This is the hypoblast and this is the epiblast. It's a bilaminar disc. And in bilaminar disc structure, this is not final, right? It will go on. Above the epiblast, amniotic cavity is formed. It is lined by amniotic cells, and below the hypoblast, the yolk sac is formed. It is a primary yolk sac, right? See, this is the hypoblast, and besides this, beneath it, what we are seeing is the yolk sac, and above this is the epiblast, and what we are seeing is the amniotic cavity. Right now you are seeing that yolk sac is larger than amniotic cavity. This changes slowly, and the amniotic cavity becomes the major cavity. Now, villi. Villi develops from the trophoblast. Now, there are two types of trophoblastic cells. We have cytotrophoblast and we have syncytiotrophoblast. Syncytiotrophoblast is like an amoeba. It's a multinuclear structure. There is no intervening cell wall, and that amoeboid structure is the one that forms intervillous space. Okay. This is the cytotrophoblast. This is the syncytiotrophoblast. What syncytiotrophoblast does is it forms the lining of the intervillous space. Intervillous space is found in placenta. We'll come across it later on, and that space is where the maternal blood comes in contact with the fetal villi. Okay. Now, this is the structure. This is the amniotic cavity. This is the yolk sac. This is the bilaminar disc, and this is the connecting stalk. The inner cell mass is connected to the outer body via connecting stalk, and this is the cavity, is the chorionic sac. The extraembryonic mesoderm, this is the extraembryonic mesoderm that is formed by the hypoblast, splits up to form a cavity. This cavity is the chorionic cavity, and it has two portions, the splanchnopleurotic mesoderm and the somatopleuric mesoderm. These two mesoderms, in between them hold a cavity, and these mesoderms give rise to further structures. Gastrulation. Gastrulation is the formation of trilaminar disc from bilaminar disc structure. The major part of gastrulation is undertaken by epiblast. Now, we generally think that the hypoblast gives rise to the endoderm, epiblast gives rise to the ectoderm, and between mesoderm is formed. That is not true. The epiblast gives rise to ectoderm, the epiblast gives rise to mesoderm, and the epiblast gives rise to endoderm. Everything is done by the epiblast, as you can clearly see, everything. Okay? So, gastrulation is that process where the embryonic ectoderm, endoderm, and mesoderm are formed. So, where does gastrulation start? First, primitive streak is formed. Primitive streak is a process in which the epiblastic cells come in the midline, they start proliferating, and they form a streak-like structure on the bilaminar disc. And that midline structure goes inside. When it goes inside, it gives rise to mesenchyme. Mesenchyme are mesenchymal cells suspended in gelatinous matrix, and that mesenchyme gives rise to mesoblast or embryonic mesoderm, intraembryonic or embryonic mesoderm. Now, cells from epiblast displace the hypoblast, forming intraembryonic endoderm. Now, this line is very important. Look, cells from epiblast displaces the hypoblast and forming the intraembryonic or embryonic endoderm. So, everything, all the three layers are actually arising from epiblast. So, generally we think that the hypoblast gives rise to endoderm. That is not true. Now what happens in the primitive streak? Nothing. It becomes an insignificant structure at the sacrococcygeal end of the fetus. So this is the entire thing. This is the primitive streak. Okay. And the cells are going inside. This is the mesenchymal area which is giving rise to mesoderm, and this is the endoderm which is replacing the hypoblast. So this is how it happens. This is the primitive node. Primitive node is the cephalic end of the primitive streak, and it indicates the head end, or it indicates the cephalic end. This is the epiblast. Now, there is another structure that arises. It's called notochord. You all have heard name of notochord. The notochordal cells again arise from primitive pit and primitive node. The cells migrate anteriorly and give rise to notochord. The notochord extends till precaudal plate. What is precaudal plate? This is the point from where mouth arises, and at this junction, the epiblast and at this point, the endoderm is opposed to the ectoderm, right? There is no mesoderm in between this point, precaudal plate, and there is no mesoderm in this area as well, the cloacal membrane. So this is the lower end and this is the head end of the baby. So what does notochord does? Notochord is a primitive structure. Initially it is very solid, and then it acquires a lumen and becomes a notochordal canal. The notochordal process grows cranially between the ectoderm and endoderm until it reaches the procaudal plate. That is the one where the endoderm and ectoderm are opposed, and the precaudal plate is the one where the primordium of oropharyngeal membrane is present. Some cells from the notochord move ahead of the precaudal plate and they form the cardiogenic area. This is the cardiogenic area. So the cardiogenic area is formed by the cells of notochord. They bypass the precaudal plate and collect here and form the cardiogenic area. Now, allantois is irrelevant in human fetus. This is the yolk sac. From there, a small protrusion is created, that is called the allantois, and then it is called the secondary yolk sac. Allantois basically formed urachus of the urinary bladder, and in adult humans, it is known as the median umbilical ligament. This is the allantoic cyst. Why does cyst happen? Since there is a urachus, it protrudes from the umbilical area. There is always a possibility of having cysts, and the vessels of allantois are the ones that form the vessels of umbilical cord. The blood vessels of allantois become umbilical artery and vein. This is an allantoic cyst. Neurulation. Neurulation means the formation of neural tube. Exactly above the notochord, there is thickening of the ectoderm, and that is called the neural plate. Slowly there is a groove that develops in the neural plate, which is called neural groove, and that groove closes to form your neural canal. From that neural canal, brain and spinal cord arises, and while the groove is closing, a crest is formed at the folds, and from that crest, the ganglia of spinal nerves are produced. This is the neural crest. While the neural canal is closing, the crest cells, they migrate and they form the ganglia. This is the mesoderm. Now, mesoderm is a vast topic, so we'll just glance through what structures are developed from mesoderm. First, this is blastocyst, the inner cell mass. Inner cell mass is divided into three portions: the ectoderm, endoderm, and mesoderm. Now, there are four types of mesoderm. There is axial mesoderm, which forms the precaudal plate and notochord, right? There is paraxial mesoderm, that means lateral to the axis, and it forms somites, which develop into muscles, bones, and cartilage. Then there is intermediate mesoderm, which develops gonads, kidney, and adrenal cortex. And there is lateral plate mesoderm, which develops somatic structures like ventral dermis, parietal serosa, and limb buds. And there is planktonic portion, which develops mesenchymal cells, connective tissue, blood cells, and cardiovascular organs. So this is how mesoderm gives rise to various body parts. The blood vessels are formed into the mesenchymal area. It's called blood islands developed there. So spaces appear within the aggregations of mesenchyme known as blood islands, and then they are generally lined by the endothelium and they start developing into primordial tubules which unite with other vessels to form primordial cardiovascular system. Toward the end of 3rd week, the heart starts developing, and it is represented by a paired endocardial heart tubes which join to form blood vessels. Now, chorionic villi formation. Chorionic villi is developing into three stages, right? There are 3 stages. First, there is inner cytotrophoblast and outer syncytotrophoblast. As you can see, there is no blood vessels inside, and there is no mesoderm as well. Now, there is extra embryonic mesoderm entering inside this area. This is called secondary villus, and from that mesoderm, blood vessels are developing inside the core of the villi. This is the tertiary villi or the final villi, right? This is the main villi of the placenta. Now, these are the derivatives of mesoderm. You can just go through it. The connective tissue, cartilage and everything develops. All major organs actually develop from mesoderm, and the most important thing I want to tell you, all the muscles develop from mesoderm. These are from endodermal lining. Endoderm ka matlab hai lining. It lines all the organs. So the digestive tube is lined by endoderm, respiratory system is lined by endoderm, middle ear, urinary bladder, everything is lined by endoderm. Tonsils, thyroids, parathyroids and thymus, these glands develop from endoderm, and since the digestive tube is developing from endoderm, liver and pancreas develop from endoderm as well. Pituitary gland, enamel of teeth, they develop from ectoderm. The entire nervous system develops from ectoderm. If you recall the development of nervous system, the neural tube, neural plate, it develops in the ectoderm. So organogenetic period from 4th to 8th week is considered organogenetic period. By the end of this duration, almost all structures have developed, but the function is minimal. Except cardiovascular system, nothing much functions in the body, but the basic structure is ready. Now it will evolve into a human body. So the phases of embryonic development are 3: growth, morphogenesis and differentiation. Growth, by growth we mean the cells are replicating. By morphogenesis we mean that they are taking the shape of a human embryo, and by differentiation means that they take the final form of the organs as it should be present in the human embryo. So we'll go rapidly by weeks. In the 4th week, by day 24, pharyngeal arches are visible. The first and second arches are developed distinct. The 3 pairs of pharyngeal arches are visible by 26 weeks. Upper limb buds are recognizable by 26 or 27 weeks, and the lower limbs are visible by the end of 4th week. Day 26, sorry, it's not weeks, I made a mistake, it's day 26 or day 27. As you can see, the upper limbs appear earlier than lower limbs. In the 6th week, we will go through the major areas. The embryo at 6 weeks show spontaneous movements such as twitching of trunk and limbs. This is an important point. It means that in 6 weeks, the nerves and muscles are connected, because a muscle cannot twitch without nervous connection. So this indicates that by 6 weeks there is fusion of nerves and muscle. They are working together. The movement may not be organized, but they are at least working together. And the embryo at 6 weeks also shows reflex responses to touch. So how did they find out? We don't know. But if you touch the embryo at 6 weeks, it shows reflexes, right? The eyes are obvious, the ear development is prominent, and lower limb development is later than upper limb. So this is the 6th week embryo. It does not look very human, but it is a human embryo. In the 7th week, there is an important event that happens in 7th week. See, intestines are very large and they are growing very rapidly. There is not enough space in the abdomen to accommodate those intestines. So what happens is that intestine undergoes herniation. Out of the umbilical ring, they enter into the umbilical cord, in the proximal portion of the umbilical cord, and this is called umbilical herniation. It is common, it is normal for any embryo. The persistence of this herniation is not normal. So if a baby is born with the herniation of intestines, which is called exomphalos, it is not normal, right? This is normal and it corrects itself by 11 to 12 weeks of gestation. And by the end of 7th week, ossification centers are appearing. Look, this is important. So you can recognize ossification by X-ray. So by 7th week, bones start ossifying. This is the 7th week embryo. Again, does not look very human. 8th week. all our digits are webbed initially, both of our hands and legs. So in the 8th week, the digits of hands are clearly visible. Okay, the embryonic representation is called digital rays. We call this digital rays when it is in the embryonic stage. So the embryonic hands are visible, fingers are visible, but they are webbed. In the leg portion, they are not very visible, but the notches are there. Okay, we can see the notches. Ossification again begins in lower limbs in the 8th week. It begins in the upper limbs in the 7th week, and in the 8th week it begins in the lower limbs. And 8th week embryo, distinctly it looks like a human being. Now we can identify it as a human. It's quite human, right? So gestational age, we can calculate it by somites. We can count the somite and compare it to the number of days, and we can calculate the gestational age. We can either calculate it by greatest length. Till 4th week, the baby is straight, so we can, when measure the length, we get the greatest length and we can calculate the gestational age. Beyond that, we measure the crown rump length or the sitting length, and beyond that, we measure the CHL or crown heel length or the standing length. So this is how we measure the crown rump length. Now ultrasound is important. Any woman who is pregnant will get an ultrasound done. Ultrasound examination, every woman in first trimester or when the pregnancy is detected needs to go ultrasound. The reasons are multiple, but I will tell you the most important ones. Ultrasound in the first trimester gives a dating scan, or we can know the exact gestational age. It's quite accurate. Secondly, it tells us the location of the embryo, whether it is ectopic or intrauterine. It is very important. Secondly, if there is abortion or not, if suppose the baby is aborting, so we can know it by the lack of heart sound, by the lack of fetal pole, or there are other parameters with which we can find it out, or if there are any uterine anomalies. So ultrasound is important. Now fetal period, beyond 8th week, means 9th week onwards, the period is called fetal period. External genitalia till 9th week is similar in both. 12th week onwards, the mature fetal form is established. The intestinal calls return by the middle of 10th week. And look, 11th week, by 11th week, intestines have returned to the abdomen. Now we'll move on system wise. CNS, look, this point is important clinically. The cranial end closes by day 8, neural tube, I am talking about neural tube. The cranial end closes by day 8 and the caudal end closes by day 40. So the development of neural tube is completed by day 40 of LMP. And that is why folic acid supplementation is advised 3 months prior to conception to avoid neural tube defects. That is the reason. Now, here embryology is guiding our clinical findings. Why we are giving folic acid before conceiving? Because by day 40 neural tube is closed. The development is almost complete. So if there is any problem, if there is any neural tube defect, it has already set in by day 40 of LMP. We don't have much time. So, and most of the time when we start folic acid is when the woman has missed her periods. So already 30-32 days has passed. So a lot of development has already begun or completed. Now the wall of neural tube gives rise to brain and spinal cord. The lumen gives rise to the ventricular system. And 6th week, 3 primary vesicles develop, and 7th week, 5 secondary vesicles develop. Now 5 secondary vesicles are diencephalon, telencephalon, mesencephalon, metencephalon and myelencephalon. These are the brain structures which each of them develop. Diencephalon will give rise to thalami, telencephalon, cerebral hemispheres, mesencephalon, midbrain, metencephalon, pons and cerebellum, and myelencephalon, medulla. The peak of neuronal proliferation, like the nerves proliferate, the peak is reached in 3 to 4 months. Migration. Why there is migration? The nerve has to migrate to different places, into the nerves, into the brain, into the spinal cord. So the peak of migration is in 3 to 5 months of pregnancy. The myelination begins in 6th month, but it progresses mostly after birth. So myelination has started, but it has not completed. It proceeds beyond birth. 1/3 of neural tube gives rise to spinal cord. The growth of spinal cord, as you all know, lags behind the vertebral column. That's why the spinal cord is smaller than the entire vertebral column. So at 24 weeks, the spinal cord is the S1 vertebra. At birth, it is at L3 vertebra, and in adults, it ends at L1 vertebra. So this is our cardiovascular system. On 23rd day, straight cardiac tube develops. Between 4th and 7th week, there is extensive growth in the cardiovascular tube. There are primitive valves are formed, and a septate four-chambered heart is formed. Now, fetal heart is quite unique. The chambers work in parallel, not in series like in the adult heart. And there are 3 sets of bypasses to ensure that the maximum blood goes to the fetal body and minimal goes to the lung, because lung is non-functional at that time. So the 3 bypasses are ductus venosus. Ductus venosus takes the blood. It's the major branch of umbilical vein. It takes the majority of blood directly into inferior vena cava. Then we have foramen ovale. It is the connection between right and left atrium. So the majority of oxygenated blood from right atrium flows into the left atrium. And then we have ductus arteriosus. It is the connection between pulmonary artery and arch of aorta. So this is the one that completely bypasses the lungs. Majority of the blood that enters the pulmonary artery from the right ventricle bypasses the lungs and goes into the arch of aorta. Hemopoiesis. Hemopoiesis means formation of blood cells. So there are 3 phases. First is the yolk sac phase, right? The first cells are formed in the yolk sac. Then we have the hepatic phase, in which the blood cells are formed in liver, majorly and minorly in spleen. And then we have medullary phase or the bone marrow phase, which starts at around 5th month, which is the main site of hematopoiesis in the fetus as well as the adults. And there is the AGM, aorta gonad mesonephros. This region is critical for generating definitive hematopoietic stem cells. Look, this area, AGM, aorta, gonad and mesonephros, is very important. It gives rise to multiple stem cells. The gonadic stem cells, both from ovary and testis, arises in this area. The hematopoietic stem cells for our bone marrow arises in this area. This is quite an important area. And erythropoiesis is controlled by fetal EPO or fetal erythropoietin. We all know that the majority of babies have HbF, that is the major hemoglobin, and the adult hemoglobin is HbA. So the difference between HbF and HbA is that HbF has higher affinity for oxygen as compared to HbA. Why is it so? Why do we need it? We need it because we have to extract the maximum oxygen from our mother. So if HbA is equal to HbA, then the baby will not be able to extract much oxygen from the mother. That's why the babies have HbF in their blood to extract maximum oxygen from their mother. Even after birth, HbF forms 60 to 80% of total hemoglobin. So it is not like that the baby is born and HbF changes to HbA. It takes time for HbA to replace HbF. Our respiratory system. Look, lungs develop from the foregut. Okay, lungs develop from the foregut, and that is the reason why esophageal atresia and tracheal atresia can coexist. And that is the reason why there is tracheoesophageal fistula, or the lungs is connected to the intestines. That is the reason, not intestine exactly, esophagus. Okay, because both of them develop from the foregut. There are 4 stages of lung development: the pseudoglandular stage, the canalicular stage, the terminal sac stage, and the alveolar stage. These are the stages where the lung bud gradually increases in size, it branches, and final alveolar form is achieved. We all know that surfactant is required for a baby to breathe, and the lack of surfactant is what develops the respiratory distress syndrome in premature babies. So surfactant is formed by type 2 pneumocytes of the alveoli, and it begins at 24 to 28 weeks. That's why in many Western countries, in America, in Europe, they are able to save the baby that is born at 24 weeks. They are able to. And many of them save the baby which are born at 22 weeks. And the reason being this: the surfactant is produced at 20-40 part, the foregut, midgut, hindgut. So foregut, esophagus till proximal duodenum, and is supplied by the celiac artery. From the distal duodenum till lateral right 2/3 of our transverse colon, it is midgut, and it is supplied by the superior mesenteric artery, and everything beyond till upper anal canal is developing from hindgut, and it is supplied by the inferior mesenteric vessel. The digestive tube has few significant events. The midgut herniation, as we have discussed, the intestines herniate into the proximal umbilical cord for rapid growth and rotation. The intestine actually rotates. It does not remain straight. It rotates, and for that rotation it herniates into the umbilical cord. And it returns by 11 to 12 weeks. Now see, swallowing and peristalsis start at 10 to 12 weeks, Intrinsic factor responsible for absorption of vitamin B12 starts to develop at 11 weeks. Pepsinogen is present in the fetal circulation at 16 weeks, and insulin is present at 12 weeks. Now urinary system, there are 3 kidney generation: pronephros, metanephros, mesonephros. So metanephros is the adult kidney, our kidney. Mesonephros provides the duct for the adult kidney, and pronephros is irrelevant in humans. However, all the 3 are required. If the kidney does not develop in this stage, there will be some abnormality. The baby will survive, as kidney is not essential during intrauterine period, but it is very much important during the postnatal period. Loop of Henle develops at week 14, and new nephrons are produced till 36 weeks of pregnancy. Endocrine system, the first endocrine gland to appear is thyroid. Okay, it appears at day 24, and it descends to its normal position by week 7. The adrenal glands are of dual origin, as you all know. The cortex develops from mesoderm, and medulla develops from the ectoderm. Okay, parathyroid glands develop from the endoderm of the 3rd and 4th brachial arc. Pituitary gland again is of dual origin. There is adenohypophysis developing from the pouch of Rathke, from the stomedium, and then there is neurohypophysis, which develops from the ectoderm. Now we'll quickly move towards placenta. Placenta has 2 portions. Okay, there is a maternal portion and the fetal portion. The maternal portion is called the decidua. Decidua only develops once there is implantation. Okay, in non-pregnant women, decidua cannot develop. So decidua is a property of a pregnant uterus or pregnant endometrium. So there are 3 types of decidua: the decidua capsularis, the decidua parietalis, and decidua bassalis. Decidua bassalis is the one that faces the placenta. Capsularis, this is the decidua capsularis. It faces outward. This is the decidua bassalis. This is the decidua parietalis. So when the embryo is burying itself inside the endometrium in the blastocyst phase, there is a layer of endometrium above the embryo which forms the decidua capsularis. Okay, this is the decidua capsularis. And the rest of the uterine cavity, there is decidua parietalis. As you can see, there is some space in the initial phase. So for 14 to 16 weeks of pregnancy, a woman can menstruate monthly because of this area. After around 14 to 16 weeks, the embryo completely fills the uterine cavity, and both of them merge to form the decidua vera. Okay, this is the decidua vera. Now, development of placenta. Placenta develops from the villi. Okay, chorionic villi. Again, chorionic villi are of 2 types: the chorion leve and the chorion frondosum. Chorion frondosum is the one that faces the decidua bassalis, and chorion leve is the one that faces decidua capsularis. As you can clearly see, the decidua capsularis has no blood supply, so it smoothens out and it becomes flat structure. This Nitabux layer is formed at the junction of placenta with the decidua bassalis. This is the area from where the placenta separates at the time of delivery. If this layer is damaged, it leads to placenta accreta, or what it means is that placenta is tightly adherent to the myometrium of the uterus. It is very difficult to remove during delivery. So this layer is very important. Now, intervillous space is what I was talking about earlier. This is the intervillous space. Okay, this is villi. This villi has cytotrophoblast inside. Inside it is cytotrophoblast, and outside there is syncytiotrophoblast. This entire intervillous space is lined by syncytiotrophoblast. And outside of syncytiotrophoblast is again a cytotrophoblastic shell. This shell is punctured at multiple places by the spiral artery, and it supplies blood into the intervillous space. Now, fetal placental circulation. Fetal placental circulation, simple. There is one umbilical vein and 2 umbilical arteries. The arteries carry deoxygenated blood and the vein carries the oxygenated blood from placenta. The arteries enter the placenta, divide into multiple chorionic vessels, and they form capillaries inside the chorionic villi, which is called the aortocapillary venous system. And then those capillaries convert into vein and they form the umbilical vein and take that blood to the baby. So in fetal circulation it is reversed. The artery is carrying deoxygenated blood and the vein is carrying oxygenated blood. Maternal circulation is from the spiral arteries, which are the branches of the uterine artery, and the blood flow is in jet. Okay, so the blood flow goes like this, and the outside there is umbilical veins. The veins are there which carry the blood back to the mother. Now there are some abnormalities of placenta. Placenta can be bilobed or trilobed. It has no significance. There is single umbilical artery. It's just there are many lobes in it. Succenturate placenta, there is accessory lobe here. If we miss that lobe, the mother can have continuous bleeding post delivery. Then there is placenta, twin placenta. Twin placenta is seen in twin babies, right? Placenta previa. Placenta previa is a very life-threatening condition. This is the normal placenta. The placenta is above. This is the marginal placenta, or it is 2 centimeter, within 2 centimeter of the internal os. This is the internal os. This is the partial placenta previa. The placenta is covering partially the internal os. Okay. Internal os is the place from where the baby will be coming out. Now you can see that the placenta is blocking the os. So if the baby tries coming out, it will push on the placenta and may lead to bleeding. And here the placenta is completely covering the internal os. So we cannot deliver this baby. There is no way to normally deliver this baby. We have to undertake cesarean section. Now that is not the issue. The issue is that it can bleed anytime, even when not in labor. And placenta accreta, as we have discussed, if there is the absence of Nitabugs layer, like in previous cesarean sections, previous operations, the placenta can be directly adherent to the myometrium, and such placenta is very difficult to remove, and it leads to placenta accreta. The fetal membranes are chorion, amnion, umbilical cord, and yolk sac. The function of amniotic fluid. Now it has been divided into multiple points. I will just discuss in simple. The amniotic fluid does not conduct heat very well, so it preserves the heat of the baby. It protects the baby from shocks and everything, and it collects. And at the end of pregnancy, it bulges in front of the embryo and forms a bag of watery. It's a watery bag. So when it bulges, it allows the head to slowly engage inside. When there is no liquor, delivery is very difficult. It becomes very dry, and it is called dry labor. The baby does not proceed. It also protects the baby from the very strong uterine contractions. So amniotic fluid in that sense is quite protective. And once the the amniotic sac has ruptured, there is rupture of membranes, then the chances of infection with the baby are quite high. The umbilical cord is 50 to 60 centimeter long. If it is too long, it is problematic. If it is too short, it is problematic. Too long, it can wrap around the baby's neck, and loop of cord around neck, it can choke the baby. When it is too short, there is chance of placenta getting separated from its base. The development of umbilical cord proceeds in 3 stages: the primitive umbilical ring, the primitive umbilical cord, and the fully developed umbilical cord. So this very long, it can wind around the neck of the embryo. Very short, premature separation of placenta. Examphilos that we have discussed. When the umbilical herniation is not corrected at around 11th to 12th week and it persists, it leads to examphilos. This is examphilos. Look, the intestines are out of the baby. The factors influencing fetal development. A baby is formed by parents, mother and father. So their genes will affect them. If the mother is too young, too old, or there are some diseases in the mother, it will affect. Environmental factors lead to epigenetic changes. Epigenetic changes are the changes in which the DNA sequence does not change, but the methylation changes. There is methylation of DNA, or there is histone modification, which changes the expression of DNA. It is either inhibited or it is either promoted. So this is not a condition by birth. It can happen because of environmental factors. There is intrauterine crowding, means when there are twins, triplets, quadruplets, and it leads to various changes in the fetal growth. If the mother has poor nutrition, again, it will affect fetal growth and development. So growth is quantitative, it's the increase in size, and development is qualitative, is the maturity of the CNS. Both are used synonymously, but both are not synonymous. So genetics will definitely affect the fetal growth. Tall parents will have tall kids, right? The boys are generally taller and heavier than girls. Parental IQ. If the parental IQ is low, baby's IQ will most probably be low. Fetal hormones. There are two important hormones in the baby, thyroxine and insulin. Both are important for fetal growth. Right? The thyroxine hormone and insulin hormone helps in tissue accretion, like the collection of content in the cells, and it helps in differentiation. Growth hormone, though levels are high, it has no role in fetal development. There are multiple fetal growth factors that affect the fetal growth development. These factors promote fetal growth and these factors inhibit fetal growth. Of course, the baby is supplying the nutrition. The baby is supplied its nutrition by the placenta, so any problems in the placenta will affect fetal growth. So fetal weight correlates the placental weight. If the placenta is bulky, the fetal weight will be bulky because there is more intervillous spaces, there are more villi, there is greater absorption of nutrients from the mother. So the baby will grow on to become a bulky baby. See, defects lead to IUGR, GST and pre-eclampsia and eclampsia. Placental circulation is low resistance circulation. If placentation is not proper, if the villi formation is not proper, then it will be high resistance flow and it will lead to hypertension in mother. The nutrient supply will not be adequate, so there will be intrauterine growth retardation as well, or IUGR. These are the maternal factors that affect fetal growth. Of course, maternal drug abuse, smoking, alcohol intake, these will affect the fetal growth. Teenage, advanced and high parity pregnancy anemia, they have negative influence. If mother has having pre-existing illness like chronic renal failure, congestive cardiac failure, that will affect pregnancy. Torch infection will affect pregnancy once, but not in a recurrent manner. Genetic disorders, if the fetus is having any chromosomal disorder, genetic disorder or single gene mutation, it will definitely affect the growth. Then there are others like socioeconomic status, natural resources and emotional factors that affect, and the baby is ready. Okay, any questions?